Hello, good morning, everyone. So, like the song says, we want to be forever young, right? First of all, I am Dr. Diana Mihai. I'm the president of the Romanian Society of Aesthetic Gynecology. And I want to see if anyone can hear me, anyone can see me. If you could just please write in the chat to see if you are here, if everything is okay. Good morning, Dr. Raluca Hera. How are you?
Good morning, everybody.
Morning. Okay, let's see if anyone is writing in the chat. Okay, now they are writing. Good morning, doctors. How are you? I see here some colleagues from Romania. I see here some doctors that already have participated in our courses for hormonal replacement therapy, where Dr. Raluca Hera is our trainer as well. Hi, how are you? If you could please write as well from where you are watching us. Where are you from? Let's see. Okay, we have Bucharest, Ukraine, Dubai, Italy, Greece, Qatar, Romania, Austria, Italy, London, Dubai, Romania, Oman, Italy, Romania, Bulgaria. Hello, Dr. Bob Geptegan. Hello, Dr. Elena as well. Sibiu from Romania, Dubai, Oman. Cuba. Wow, from Cuba. What hour is in Cuba now? Lithuania, Saudi Arabia, Albania, Qatar. Okay, we still are waiting for some of our colleagues that are going to join. But so I just been at the Longevity Summit, and what they were saying is that please don't die in the next 10 to 15 years because we will not be able to bring you back alive. But if you don't die in the last 10 to 15 years, you will be able to live at least 130, 150 years old, but live it with like perfect health shape, perfect mind shape, and perfect emotional shape, because this is about not only to live longer, but to enjoy life, to enjoy children, grandchildren, grandchildren, and to be healthy and with strength and with good mind as well, because mind is very important. Maybe you have a good body, but if your mind is not working, you are not you anymore, right? You might have your hand, your hair, your body, but without your mind, it's not you. So let's see how we can use peptides. Today we had another courses about hormone replacement therapy. We had other webinars and courses about Dutch test. Today we're going to bring another tool that we have available, and that is the newest tool, the peptides, but still it's under our vision for the last years, but now it's gaining more and more trust, safety, and it's very important to what we recommend to our patients or to ourselves as well, is to be safe, to have good effects, because we all know that the first rule of the doctor is not to harm, right? Okay, so let's see. Very interesting things we are going to learn today. Dr. Raluca, I am very happy that we are doing this now. I was looking forward to it in the last 2 years.
Indeed, yes, because this is an emerging field and it's very dynamic, it's evolving very quickly. And this is why I stated this version also of the webinar 1.0, because probably in 6 months from now, we are going to do version 2.0, because I think not only peptide protocols or peptide stack protocols are important to know, like buy a peptide online and how to inject it. But moreover, it's important to be safe, like you said. So to know exactly what to counsel your patient, what to recommend your patient, what to test in your patient, how to monitor your patient on peptides, and how to integrate the peptides in the longevity protocols you are recommending, you are personalizing for your patient, along with hormones, along with supplements, and so on. So I think this is the mindset we need to set in this webinar, and this should be actually a starting point for your peptide journey, actually. So can we start
Yes,
already?
I already
I
made
will,
a post. You can share your screen.
yes, and I will share my screen. And meanwhile, you can also write, please write where you are from. This is very interesting. It's probably night or afternoon at your place, or very, very early in the morning. And besides, I would like also to know what specialties you have, because peptide is maybe more than hormones, a very broad spectrum field, which can be applied or inserted, implemented in your practice by doctors of a lot of specialties. Because as you will see, we do have peptides to be applied in different medical fields. So I think this webinar and further on the development of the peptide training is not only for certain doctors, but for all doctors, for all specialties. You can implement it in your practice. So with no further ado, I will start and welcome everyone again. And thank you for being here. And like I said, today we are going to open a conversation, because in 1 hour, of course, there's hundreds of peptides. We cannot mention protocol for each peptide. And like I said, this is not the main point, to know to inject 0.1 or 0.3 from a peptide. I believe this field, as I said, is becoming very important for all physicians, but most of all, it is important how to approach peptide medicine in a way that is scientifically grounded and clinically useful and defensible. So basically, this webinar is not designed to give you a list of fashionable peptides or quick protocols, which the social media is full of. It is designed to show you why peptide medicine needs structure. As with the hormones, we did the same, and this is how you gain confidence and responsibility and gain your name in this field. So we would like to move through mechanisms, evidence, safety, monitoring, and clear clinical boundaries in the peptide field. So my goal is that by the end of this session, you will understand why this field is promising, because it definitely is, why it is also risky when you recommend it or you learn it superficially, and why physicians need to lead this conversation with maturity and precision.
Before we start, just 1 second. I wanted to tell them, if you have any questions, please write in the Q&A session, because in the chat we will discuss different things. Dr. Raluca will ask you during your conversation if you have any, maybe you have any, if you already are prescribing peptides, for example, or other things. And in the Q&A, if you have any case or any question for Dr. Raluca, okay? The Q&A is, if you don't find it in the near the chat, it will be a round thing with 3 dots inside. Just click on it and you will have a question mark, and it says Q&A. Okay, so there write your questions, and after the presentation, we will take some questions and we have some discussions at the end. Okay, thank you.
Okay, thank you for this housekeeping rules. Just to mention that this webinar is presented in collaboration with the Romanian Society of Aesthetic Gynecology, and I'm very pleased to bring this topic into a serious physician level educational environment. In my role as a coordinator of the SREG Hormonal Treatments Board, I see the same pattern again and again. So I see a lot of patients asking about therapies before physicians have had access to structured medical education on them. So I talk with a lot of physicians who are coming along, patients who already want peptides because they read a lot, they see a lot, but they don't trust what they see on social media, which is full of protocol stacks. And they ask the doctor. And then the majority of doctors are still unprepared. So peptides in this respect are a perfect example. Hormones as well, but I hope hormones start slowly to become usual in your practice. So where sit peptides? Where is this peptide field to be introduced? It sits between endocrinology, metabolic medicine, longevity, regeneration, immune modulation, sexual medicine. So it's a nucleus field which can be addressed by several specialties. And that is exactly why they cannot be approached casually. They require a framework that respects both innovation and responsibility because you have just one specialty. So you judge through your own specialty, but nevertheless, if you recommend peptides, you will need to recommend peptides from more fields because the patient is not going to get a peptide for inflammation from internal medicine and a peptide for sexual medicine from you as a gynecologist, or a peptide for regeneration from an endocrinologist. You need to have the whole stack prepared for your patient, and of course know what is compatible one with the other and how to stack them. So let me start with a question that, in my opinion, defines the entire field. Your patients are already using peptides, or most of the patients, they are already using. Like I said, social media is full. ChatGPT or other AI platforms, I must say, they are really reluctant. I have made a thorough search on certain AI platforms, and I could not get many informations. And you will see in this webinar why this is the case. So the only question is whether the patients are getting information, products, and guidance from you as a physician, or from a website, a med spa, a social media protocol, or a person with no medical responsibility for the outcome. So this is not a future problem. This is already happening. Probably it happens in your practice as well. You might state in the chat if you are facing these problems. Patients coming already taking peptides and coming for seeking your opinion. And when a patient buys something online and develops symptoms, complications, or unrealistic expectations, they often return to you as the physician. This is the situation. They're not coming up front, they're not coming before, they're coming when something bad is happening. So we have to decide whether we want to react after the fact or lead the conversation from the beginning. So mark yourself as a leader in your community, as an authority in this field. Then they would come to you from the beginning. Before we go further, I would like to hear from you in the chat. Please type the number that fits your practice. Have you had a patient ask you about peptide in the last 30 days? So type 1 if yes, often. Type 2 if it happened once or twice. Type 3 if not yet. And I will give you a few seconds. And this is important because it tells us whether we are talking about a theoretical topic or whether this has already entered your consultation room. Let me see. 1, 3. Majority is 3. Okay, 1, a lot. Okay. Okay, so you are already dealing. So there's a lot of 1 and 2s. That means you already have inquiries about peptides. That is wonderful. Perfect. Keep writing. I will move further. So I want to be very clear about the positioning of this webinar. This is not a protocol list webinar. Like I said at the beginning, it's not about memorizing which peptide is used for which symptom. It is because there are hundreds of peptides. We would not have 1 hour would not be enough to mention all these peptides. It is a clinical reasoning webinar, and before any peptide is selected, the physician has to answer 4 questions, and these are the 4 questions. 1, is the patient a candidate for peptides? Because you cannot recommend peptides with your eyes closed. You need to see if the patient is a good candidate for it in order to not mistake him. What evidence, the second question, what evidence supports this intervention? And where does that evidence stop? You will see patients are informed. There are a lot of information all over in the media about peptides. And then they are asking you, is this a research peptide? Is this FDA approved? And so on. So you need to know. Number 3, what must I monitor before and during use of peptides? And number 4, what should I never promise? Very important. If you can answer these 4 questions with clarity, you can practice in this field far more safely than someone who simply memorizes protocols. So answer yourself these 4 questions. If you, especially those of you who have answered number 1 at the previous question, if you can face and respond and answer to these 4 questions before you write a prescription for peptides for your patient. One of the biggest problems in peptide medicine is that the same word, peptide, is used for very different realities. Because a peptide may be an approved drug, and we will see later on what categories of peptides are already approved, which is amazing. So they can be an approved drug with a defined label, real human safety data, and a clear indication. Or it may be an off-label use of an approved medicine, which can be legitimate but requires justification upon prescription, requires also consent and documentation. Or the third case, a peptide may be investigational. There are a lot of peptides under investigation still, meaning human data may exist, but it is not routine clinical care. It needs to be studied further. And the fourth category of peptides are the research use peptides, the gray zone peptides. Probably you have patients who are asking you, I personally have patients who are asking me, tell me more about the gray zone peptides. They are curious, they would like to try them, but still they are reluctant, they have fear, so they want to know more from you in order to take a decision. These research use or gray zone peptides often are in preclinical trials, and highly sensitive from a regulatory and safety perspective. Patients usually cannot tell these categories apart, these 4 categories apart. Patients just know peptides, but you need to know these 4 categories. And you need to be trained formally to separate these categories and know them very well. So when you don't have a framework, patients do not stop searching. They go elsewhere because they are so convinced that peptides can do magic in their lives. So they want to take peptides. And I have patients who rather would take peptides than hormones. In my protocols, I always stack hormones first and second peptides. But there are a lot of patients who have fear of hormones, who are FDA approved. We have standardized products for hormones, and we know their benefits in a lot of areas of our health and physical appearance. Still, they prefer peptides who are maybe in the gray zone or not very well studied instead of hormones. I don't know why. Probably there's a paradigm, there's a misconception, but anyways, we will deal with a lot of inquiries on peptides, like I said, maybe rather than hormones. So as I said, they will not stop searching. If you cannot tell them about peptides, then they will go elsewhere. And where will they go? Where the peptides are recommended very easily. Med spas, online clinics, websites who are selling peptides, or other informal networks. Some gray market products which are found on these websites have been found to vary a lot in purity, and some products contain ingredients that are not even listed on the label. So be careful where you buy peptides. Patients may pay, really, they are expensive, yeah, hundreds of euros or dollars per month for compounds that may be contaminated, mislabeled, or inappropriate for them. And then if something goes wrong, the physician is still expected to manage the consequences. And that is the worst position to be in. Patient is already taking peptides, has a complication, and comes to you. So you don't have control, you don't have oversight, and if you accept the patient, then you take also the responsibility. So like this slide also says, according to data we found in the literature, in the gray market, purity ranges in the peptides found in the online market is to 5 to 75%. 1 in 4 products are contaminated with ingredients who are not even on the label. Okay, but patients pay around 500. It's the minimum we found, around 500 euros per month for peptides. Now I would like you to answer another question, a second quick poll. If you have already seen a patient using something they bought online or received at another clinic or med spa, or not through a physician. Type 1 if you have seen such patients, if such patients came to you. Type 2 if you suspected it, and type 3 if you don't know that, not such patients. And again, this is not meant to be scientific polling. It's meant to show us the reality in the room. Many of us are already managing peptide exposure, and whether or not we formally decided to offer peptide medicine, it is the reality which we are confronted with. So let me see what you answer to these questions. So majority of you don't know that. Okay. Okay, let's move forward to the education problem. Because this is the most important for you if you want to prescribe peptides. And I highly advise you to start to prescribe peptides, because if prescribed correctly and monitored correctly, they really can have a lot of benefits. So, but I would like to state that most peptide education is built backwards. It starts with benefits, stacks, dosing recipes, personal experience, and before and after claims. And those are things that attract attention, but they're not the things that protect the patient or the physician. And what is often underemphasized is the evidence hierarchy, the contraindications, the regulatory status, monitoring, stopping rules, and documentation, because sometimes we are afraid that we would lose the patient if we start telling him about, but this is the reality, and we need to be very honest with our patients. We need to start with these right box here. We need to start with this often underemphasized aspects of peptide. Start with this in your discussion with the patient. Where sits this peptide in the hierarchy? What category is this peptide? Does it have contraindication? What is its regulatory status? What does the patient need to monitor? And then go to what benefits could he have? How long? What are the cures, the stacks, the dosing, and so on? These are details. First of all, establish if the patient is a good candidate, and if, after you have told him all these information about the peptide, he or she is willing to pursue further. Okay. So basically, when we learn about peptides, because as I said, this webinar is intended to be the start of a journey in the training of the peptide field. So if you pursue further with the training in peptides, then we have to reverse the order. We start with clinical reasoning, not with, wow, enthusiasm, it is going to do magic in your body and so on, and in your face, and you will look amazing and so on. No, we will like to start with the clinical reasoning, with a grounded explanation for the patient. And of course, benefits matter, but they only matter inside a structure that also includes risk, patient selection, and boundaries. It's very important. And then you will have success. And the patient will also feel that he or she is responsibly guided through this therapy. Another dangerous assumption is that because peptides are biological or similar to natural signals, we will see that in a minute, they are automatically safe. It's like just with the bioidentical hormones. And this is not how medicine works. As you might well know, if you have also joined the hormone courses, you have seen that there is the same comparison between bioidentical and the body identical hormones. It's the same here. So safety depends on identity, on purity, on route of use, dose, duration of use, proper diagnosis to recommend that certain peptide, metabolic status of your patient, very important, immune status, cancer history of the patient, pregnancy status, medicines, concomitant medication, which the patient is taking, and of course, a proper monitoring plan. For example, a peptide used topically, for example, like the GHK-Cu peptide, the copper peptide, is not the same as a peptide as the same peptide injected systemically. They do have different benefits, different effects, different doses, different duration of use. A peptide discussed in an animal model, which is the case in the first trials of researching a peptide, is not the same as the same product used in a real patient or in a healthy or with comorbidities patient. So it's the total different things. So a safety first plan begins before the peptide is even selected. The patient selection, very important. Peptides are attracting so much attention because they sit at the intersection of many fields, like I said in the beginning. And this is very interesting and also very appealing. So basically, like I said, all doctors could recommend peptides. This is why the training is so important. They touch metabolism. So we have peptides for metabolic problems, endocrinology problems, longevity, for regeneration, for immune modulation, for sexual medicine, for neurocognition or prevention of neurodegeneration, or even treating, for aesthetic medicine, for sexual medicine, I said. So it is important to know all the peptides in these categories, to know how to combine them, if they can be combined. And also, today we do not have the time to address this, but very important are also the cofactors you are adding in a treatment in a peptide protocol. Yeah, cofactors like supplements, like nutrients, vitamins, like lifestyle. Like, for example, if you choose a peptide for muscular mass or for muscular recovery, then it is very important to add this to this patient a proper supplement protocol and also a proper training protocol. When does he or she need to take the peptide? Before or after the training? For how long? And so on. So it's very important to see these peptides as chapter in a whole treatment protocol, not isolated. And it is important to say this clearly as well. Peptide medicine is not imaginary. Peptides have already changed mainstream medicine. And here I have listed the peptides that are already FDA approved, very safe, and are used in a broad manner. Semaglutide, tirzepatide, which is coming now, liraglutide, tesamorelin, teriparatide, HCG, which is for a long time on the market, gonadorelin, and oxytocin. These are examples of peptides or peptide-related therapies with legitimate medical use, depending on indication, of course, and jurisdiction. But the success of approved peptide drugs does not validate every peptide being sold online or discussed on social media. So we need to stick to these FDA-approved peptides. This distinction is essential. Approved peptide medicine is real. That does not mean every peptide claim is clinically valid. And this is why I said this is a 1.0 version of this webinar, because from the beginning of the year, there are 2 or 3 peptides have already been FDA approved, and the process is ongoing. So more and more peptides are FDA approved, which is really very encouraging. And this is why it's important to already learn this peptide field, to stay up to date with it, because it is just emerging. It is just at the beginning. So just like a graphic example where we are now in the peptide field. We are in a window where patient demand, commercial interest, and medical innovation are moving very quickly, but still we are on an ascending curve. You might well know that GLP-1 therapies, even GLP-2 and now GLP-3 are coming along, have already reshaped the public awareness of peptide-based medicine. I think 80% of the population on this earth are taking a product, a GLP product. Longevity medicine is also expanding, and peptides are a very important stock in the longevity protocols, like I said, along with supplements, hormones, lifestyle measures. And patients are increasingly willing to pay privately for interventions they believe will improve body composition, energy, aging, sexual health, or recovery. Because the advantage of peptides is that they touch so many fields and they can be combined, but you need to really know, find out what your patient needs in the particular stage of life where he is. In a few years, this field will likely be more crowded, more regulated. Like I said, this is very dynamic and more competitive. The physicians who develop a serious framework now will be better positioned than those who enter later with only superficial knowledge. So like you see here, I put some numbers. Regarding GLP-1 market today, over $60 billion. 1 in 8 adults have already taken GLP-1 receptor agonist medication. And the longevity medicine is heading toward a $1 trillion scale. So this is, in 3 to 5 years, this will be a standard of care. And the physicians who lead are the ones who move now, not later. So this creates a fork in the road. Physicians, so you may wait until the market is saturated and then compete as one voice among many, or you can lead now. You can start leading now. You can start gain knowledge now with a more mature standard. So what means leading in this field? That does not mean to prescribe everything a patient requests. By no means. It means becoming the physician who can say yes when it is appropriate for a patient, or to say no where it is not necessary, and explain both situations with authority and confidence and responsibility. So clarity in this field becomes a competitive advantage. So patients do not only need access because they already do have access to peptides, they really need clinical judgment. Yeah. So briefly, we will cover today, like I said, 1 hour is probably even 10 hours are not enough for the field of peptides, which are now under development. But I would like to briefly discuss today why peptide medicine matters now. Then we will discuss why much of the current education is incomplete, which is obvious because it's such a new field. After that, we will go into the science a little bit, biology, mechanisms of evidence, and then I will introduce my clinical framework, the Hera Medical Institute clinical framework, the structure that we use to assess every peptide. And we will then look at the major peptide categories through this lens. And finally, I will show you what the full physician level course includes, because like I said, this webinar is meant to be the origin, the starting point of a longer journey. And I created this webinar and later on the training because this topic has entered my own clinical world already. So I'm a gynecologist. I'm practicing. I'm board certified in EU and also in Switzerland. I have a PhD from the Technical University of Munich, and my clinical work is centered on hormone treatments, longevity, functional and preventive medicine, and aesthetic cosmetic gynecology. So at Hera Medical Institute in Bucharest and in Zurich, I work with patients who are highly informed, highly motivated, often exposed to medical information from many sources. And what I saw was a problem: peptide claims spreading universally without hierarchy. Patients exposed to internet protocols, buying online, too little attention to safety, and confusion around what is even legal. And I would like to answer to this problem in this training I have developed in the peptide field. What do you think? Just answer briefly before we move into the scientific foundation. Does this picture, which I have described you briefly before, match what you are already seeing in your practice? Type 1 if yes, exactly. Type 2 if partly, and type 3 if not yet. Because there is no right or wrong answer. It's just to understand where you are at this point. And some of you may already be dealing with peptide requests every week. Other may be earlier in the curve. Either way, the field is moving toward us. So let me see. 2, partly. Yeah, okay. 2, 3. 2, 3, most of you. Okay. So what are peptides? Let us start with the foundation. Peptides are amino acid sequences that act as biological signals. An amino acid sequence becomes a peptide. A peptide then interacts with a receptor or biological pathway, and that signal may produce a clinical effect. But the question mark on this slide is essential. A biological signal does not automatically equal a proven clinical effect. So sequence matters because small changes can alter half-life, receptor affinity, route of fuse, and safety. So the sequence of amino acids in a peptide is very important. Also, the signal matters because peptides may act on endocrine pathways, on immune pathways, metabolic pathways, neuronal pathways. And evidence also matters a lot because mechanism alone is never enough for a clinical claim. So evidence is very important. And you will see in a minute why. Because not all peptides behave the same way. Some are endogenous and mimic the body's own signals. Other peptides are synthetic analogs, engineered to last longer than having a longer half-life than the endogenous ones, bind differently or act more selectively. Route of administration also matters. Oral, subcutaneous, topical, intranasal, they're different and they do not support the same claims. Yeah. And we cannot take a peptide orally if it has a too long sequence of amino acids, because this is not going to be absorbed. So it is very important to know which peptide can we administer orally, for example, which are very few, like the ones with couple of very few very small sequence of amino acids versus the other ones who will need to be administered injectable. Half-life and receptor affinity are also very important because they influence duration of action, and this is going to orient us the cure duration, the frequency of administration. It's very important to know what to tell the patient, frequency of use and off-target risk. And this is why we have to be very careful when translating a mechanism of action into a clinical statement. Yeah. And this is only the beginning of the research question, yes? So when a peptide is started to be researched, these are the mechanisms which are first analyzed and reviewed. But from here until the peptide FDA approved in a bottle, there's such a long way. There are a lot of trials, not only clinical trials, but only human trials. And not every peptide is succeeding in this route. Not every peptide is going to be FDA approved. So this slide is one of the most important in this webinar. A mechanism, like I said, is not a proof. A plausible mechanism may lead to an animal model in a certain effect. An animal model may lead to a human biomarker study. If it's right, if they see in an animal model the peptide is working well, then they might lead it to a human biomarker study. Then a human biomarker study may or may not lead to a meaningful clinical outcome. Only after that do we reach an approved indication. And many peptides, like I said, never reach that point. Most peptides stop somewhere along this pathway. And the physician's job is to know where they stop and to say so clearly. Because on the market, on the online market, you can find several peptides which are not here, which are here somewhere on this pathway, but they're still for sale. So you need to be responsible and to know where the peptide you are recommending is sitting. Okay. Patients hear very powerful language. They hear that a peptide repairs tissue, boosts mitochondria, restores immunity, reverses aging, fixes sleep, gets them better recovery after physical exercise. But you need to translate that promise into a clinical question. What endpoint was actually measured? And I'm talking about this pathway here. Was the evidence human in this peptide or was it animal? In which population, if human? How many subjects were tested? By which route? Of course, you will not know exactly which peptide on how many patients it's been used, but in the training, we will categorize peptides on evidence support. So you will immediately have an overview. If you look up a peptide, in which category does it stand? You will have it at a glance so that you may or may not recommend it. Which is the best route has been studied for the peptide. What dose, what safety signal. So the same peptide, like we mentioned before, can have different conversations. The patient-facing promise is often broad, emotionally attractive, because he sees like something magic happening with him if he's going to take that peptide. But the physician level boundary, your rationale must be really precise. For example, let's check the BPC 157. Let's do a quick check in the chat, because BPC 157 is everywhere online. Yeah, everybody has heard of BPC 157. Where does its human evidence actually stop? What do you know about this peptide? Type A, if you believe it is an approved drug. Type B, if you believe there are large randomized controlled studies, trials. Type C, if you believe there is a small human data on these peptides. And type D, if you believe it is mostly preclinical. And we will come back to this later, because BPC 157 is one of the best examples of the difference between popularity and evidence strength. So let me see what you know about BPC 157. D, mostly preclinical. Well, everybody is answering D, almost everybody. C, small human data. Okay. Okay, so if you remember only one thing from this webinar, let it be this: peptide medicine is not a list of peptides. And I think I have already talked a lot about this, and I have convinced you about that. It is a decision architecture. The list of peptides will change. Now there are hundreds of peptides upon where not many are FDA approved. As a matter of fact, there are very few FDA approved, but the list will change continuously, and the doses and so on. So new products will appear, regulatory status will shift. It's an ongoing process. Studies will be published, and some popular compounds may disappear also. But the decision architecture remains useful, remains the same. It teaches you how to think when the next peptide appears, not only how to repeat what someone told you about the current ones. Okay, it's very important. So my framework that anchors actually the training. Every peptide is taught through the same pattern. And this is a framework, an architecture you should learn by yourself and go through it whenever you are prescribing a peptide to a patient. Same pattern: promise, evidence, safety, monitoring, and clinical boundary. Promise means benefits. What is it claimed to do? Evidence means where does the data actually stop? Safety means who should never receive that peptide or who requires special caution. Monitoring means what do I measure and when? Because with each peptide, we will have a list of lab tests necessary before and during the treatment. Clinical boundary means what must I never promise? That's very important. This framework turns basically enthusiasm into a clinical reasoning, and it should be communicated as such to your patient. It is simple, but changes the entire conversation. And you might lose some patients, like I said, and other patients will be so confident that they will stick to you because they will know you are responsible in what you're doing. To prevent overclaiming, we will use a simple evidence hierarchy. Like I said, now I am going to give you the 4 major categories, but in the training, you will have in this category all peptides listed that belong to the respective category. Group A includes approved drugs with strong human data. Group B includes compounds approved somewhere or used clinically in some regions. Group C includes investigational peptides with limited human data. Group D includes mostly preclinical, research use, or gray zone peptides. And we also flag a C negative group, meaning peptides with human data that is weak or negative. This is a very important category because many people say there are studies on these peptides, as if that would be enough. But a study can also show limited benefit or no effect or no benefit or an unfavorable risk-benefit profile. These are also studies. So being studied, a peptide does not mean it is also beneficial. So you look up the studies. What do they say? So this is the C negative category, where there are studies, but they did not show benefits. or they did not show a favorable risk-benefit profile for the respective peptide. And on the online market, you will see peptides from all these categories. They are not flagged with a certain category type. You will not find them flagged. This peptide is category A, this peptide is category C. You will not know. If you don't know where these peptides are, then you don't know what you're buying or your patient. So this spectrum shows how different the evidence can be under the same word, which is peptide. At the strongest end, we have therapies with robust human evidence, like GLP-1 agonists, with large human trials and approved indications. Then we have moderate human evidence peptides with limited clinical studies. For example, for selected growth hormone axis agents, secretagogues, where monitoring is essential, like sermorelin, ipamorelin, CJC. Then we have mechanistic or animal dominant peptides, such as BPC-157 and TB500. Human trials in these peptides are essentially absent. So these are investigational peptides. Human evidence is extremely limited. And finally, we have longevity signal peptides like epictalon, GHKCU, copper peptide, where much of the discussion comes from in vitro or rodent, mechanistic or historical data. So it's very important. In the training, we will teach to locate each compound honestly on this spectrum and be responsible in what you are recommending or even administering. Why is this important? Because this hierarchy to know is protecting you. It avoids treating all peptides as equal. It prevents extrapolating animal data into patient promises. It clarifies approved off-label and investigational use, what that means. It supports documentation and patient communication, and it creates a defensible education framework. A key principle is that evidence level and benefit domain are not the same thing. And I think right now, after almost 1 hour of talking, you are already convinced about that. A peptide can belong to one of the fields, metabolic, immune, regenerative domain, and still have weak clinical evidence. So domain tells you what area is discussed in, but evidence strength tells you how confident you can be in that domain, okay? So domain and strength are two different axes. Regulatory status changes also the conversation. So the clinical enthusiasm is not the same as the legal clarity, and an approved drug, an off-label use, a compound preparation, an investigational product, a research use peptide, a gray market online product, all require different thinking. They differ in sourcing, they differ, the consent from the patient is different documentation, patient communication, and what claims can be made. And you cannot simply ask, could this work? You need also to ask, what is this legal, if it is legal, if it is in my jurisdiction. What am I allowed to say or to do with this peptide in communicating to my patient, in stating that in my practice you can do peptide therapy? Yeah. So you need to set limits, but you need to be aware where you stay with what you are prescribing. The regulatory landscape is moving in both directions. Yeah. So some legal pathways exist under physician supervision, depending on country and category. At the same time, gray market enforcement and safety scrutiny are increasing. Research use only language is not a legal route to patients. So you need to take this into account. Some peptides are being flagged for safety risk or restricted compounding. Both directions means there are peptides emerging getting approved, while others are dysregulated and withdrawn from the market. Then sports medicine is also a very important field. It adds another layer because WADA status matters for competitive athletes. Maybe you have such patients, and then you need to know what peptides am I allowed to prescribe these patients who are competitive athletes. Maybe they don't know, but you need to know to comply with the WADA restrictions and regulations. So the practical point is simple. Sourcing and documentation carry real liability, and regulation is not a side note. It is part of the clinical reasoning. It's very important. We all like peptides. Maybe you take peptides and you see how beneficial they are. But in front of the patient, we really need to be very responsible, and we really need to face the reality which we do have in this field and move with it. So get updated constantly, move with it, because it is going to progress. This is the peptide category map we use basically, and in the training, in the course, we will talk about these main categories of peptides, but complying the same framework which we have discussed before. So we will look up metabolic peptides, growth hormone axis peptides, immune modulation peptides, gut barrier peptides, regenerative peptides, mitochondrial support peptides, then longevity peptides, neurocognitive peptides, sexual and reproductive peptides, and last but not least, skin and aesthetic peptides. But we will always look at two axes at the same time. The first axis is the clinical domain, what the peptide is claimed to help with. And the second axis is evidence strength, how much data actually supports that claim. So that we do not confuse these two axes. It's one of the most common mistakes in this field. Yeah. For example, let us apply the framework to the metabolic category, the GLP-1s and the GIP therapies. They are not simply aesthetic weight loss tools. They sit inside obesity medicine, diabetes care, cardiometabolic risk, and body composition management, and they do a great job. And I have patients on GLP-1s, and maybe I'm sure you have a lot. And I really can see how their biomarkers are dropping simply by taking these GLP-1s. Not only their weight is dropping, but also their biomarkers. They're doing amazing in terms of metabolic flexibility. But you need also to ask about their muscle mass when you see those patients, their protein intake, their resistance training, for example, their gallbladder history or situation, their gastrointestinal motility, their pregnancy plans. So the boundary is very important when you administer or you monitor or supervise a peptide. It is very important. Aesthetic weight loss in case of the GLP-1s is not the same as metabolic medicine. Yeah. So basically, when we teach in the training a peptide, like for example, the GLP-1, we will also look up at protocols for muscle preservation, because weight loss without muscle strategy can create long-term risk, especially in midlife or in older patients. What cofactors do we need? What nutrients do we need to add? And so on. So in the training, we will look up from different angles for a peptide. First of all, safety. Then what dosing protocols do we recommend for this peptide? Either it is a standard FDA-approved dosage protocol or a recommended through the actual clinical studies. And then we will take a look at the global image of the patient who is taking the certain peptide. What does he or she need to take into account as well? This is the boundary for metabolic peptide medicine, because GLP-1, talking about it, I have chosen this example because it's the most used one. And GLP-1 and GIP therapy should be framed through diagnosis, risk, body composition, nutrition, resistance training, and long-term monitoring. And this is how we will obtain the best benefits in the patient with GLP-1s and with other peptides as well. Yeah, this is especially important, for example, in normal BMI or longevity-oriented patients where you administer microdosing of GLP-1, for example. You don't administer GLP-1 for them to lose weight, but to maintain metabolic flexibility. This is a very, very interesting tool and very useful. So basically, you need to see what can we promise to this patient. If he needs to lose weight, then we need to adjust the dose for him to lose weight, and we will promise weight loss as the only endpoint. If the patient does not want to lose weight, then we need to communicate something else, other benefits of the GLP-1 medication, the microdosing for this patient. Yeah. Also, we avoid using these therapies without a plan for muscle preservation. So important. And we avoid ignoring sarcopenia risk because patient is not aware, for example, of sarcopenia risk during these treatments, these cures. Yeah. We discuss with the patient diagnosis, cardiometabolic risk, assessments like DEXA or BIA, body composition, protein strategy, resistance training plan, and follow-up monitoring. So this is how we discuss the peptides. It's not just like you take the bottle, you reconstitute it with 3 ml of bacteriostatic water, and then you push out once a day 0.1 and you inject. No, that's not peptide training, and that's not how you communicate to your patient. It's a lot more. For example, the GH axis, the hormone growth axis. Let's take another example, also very claimed. Yeah. Also, the peptides in the growth hormone axis, which are secretagogues, different intensity levels, different combinations, they require particular caution because the claims are very attractive. Yeah, they improve sleep, recovery, body composition, repair, vitality, and that is true. But this is endocrine physiology. Yeah, the physician has to ask then about some lab tests before prescribing this peptide, about IGF-1, glucose, insulin, certain symptoms to monitor, like overdose, for example, edema or carpal tunnel syndrome, sleep apnea. You need to ask about malignancy, oncologic history, very important. The boundary is essential. So low or normal IGF-1 is not automatically an indication for prescribing growth hormone peptides. Or fatigue. Fatigue is not automatically meaning growth hormone deficiency. It can mean a lot of other causes. So we need to investigate the patient before we prescribe him a peptide like a growth hormone peptide. And keep in mind that a secretagogue is not the same as a recombinant growth hormone. They are different. Competitive athletes, for example, require WADA-aware counseling in prescribing these types of peptides, also to keep in mind. Yeah. So basically, what we are going to do in the training is do a GH-axis peptide safety algorithm, which comprises growth hormone, recombinant growth hormone, IGF-1 receptors, peptides, or secretagogues. So this is a very broad area spectrum of peptides concerning the GH axis, and very interesting because each of them have different differences in the mechanism of action. So different indications, and it's very nice if you know all these to play with them for different patients, to know, this patient would benefit from this type of GH axis peptide, not the other one, and so on. So speaking now of the growth hormone axis, the message is, like I said, don't prescribe growth hormone only on the base of low or normal IGF-1. This is not an automatic indication. Just one example. Or fatigue, or poor recovery. These are not automatically peptide, growth hormone peptide indications. IGF-1 must be interpreted in clinical context. Yeah, we avoid treating a number. We treat the patient. We avoid ignoring, for example, glucose intolerance. Yeah, because we know that administering a certain type of growth hormone peptide is going to increase his insulin resistance. So it's very important. While other growth hormone peptides do not do this. So very important, the metabolic context of the patient to orient us what type of growth hormone peptide to recommend. Yeah. Also, in administering growth hormone peptides, we need to avoid. We need to document very strict the malignancy history, oncologic history. Yeah, or sleep apnea if he has. Okay. So interpret also, I always IGF-1, interpret with caution, interpret in context. Growth hormone is a very good hormone, very good peptide to administer, but with a proper indication. Screen for metabolic and clinical risk. Also, depending on the patient, if he's an athlete, respect the WADA regulations and off-label restrictions, and of course, document everything properly. Now we got into couple of details, but anyways, let's move to another category of peptides, which are the immune and inflammation peptides. In this peptide category, very important the language, how you communicate the patient. Modulation is not stimulation. So don't tell the patient it will stimulate your immunity. No, it will modulate your immunity, because patients may ask for immune boosting. But you, as a physician, should think in terms of immune regulation, inflammatory pathways, infection context to be checked, and autoimmune risk also. So you need to check the patient thoroughly. For example, thymosin alpha-1, KPV LL37, AR8290, they are discussed in this category, and before prescribing them, you need to ask about autoimmune history, active infections, immunosuppressive medication, malignancy context, and the responsible claim. Why do you prescribe? What is the benefit you are targeting with prescribing these peptides? And I would recommend you, I would advise you to avoid the term immune boosting, to avoid presenting these peptides as cures for infection, cancer, or autoimmune diseases without indication-specific evidence. So be very careful. Next category would be the gut barrier peptides and the BPC 157. They deserve a dedicated module because this is one of the most requested areas by the patients. Yeah, gut barrier biology is real and it's so important. Yeah. Also in terms of gut-brain axis. So it has a lot of consequences, also in terms of hormone metabolism and nutrients metabolism, metabolic flexibility. So it's very important to have a really solid gut barrier. But the human evidence, like we said, for BPC 157 is not where online claims suggest it is. Patients may ask for gut repair because, you know, BPC 157 in the oral form is claimed to repair the gut barrier or to normalize the microbiome. So in the oral form, it has gut benefits. So patients may ask, because they are reading, they may ask for gut repair, mucosal healing, or a peptide to heal the gut. Yeah. But either way, even if you decide to recommend the patient BPC 157 in oral form, in form of capsules, ask and do a differential first, whether there are red flags such as bleeding, anemia, weight loss, check their gut through a colonoscopy, through a microbiome test maybe. Yeah, so do a gastroenterologic evaluation when necessary before prescribing for gut healing BPC 157. Yeah, and the boundary here is very clear. Do not promise oral BPC 157 efficacy. I mean, it is not replacing diagnosis, and don't use this gut miracle language like it will heal your gut. Just make sure first that you have done a good differential before adopting this recommendation. Next category would be the regenerative peptides. They're another high overclaimed zone, tissue repair. Tissue repair is biologically plausible, but plausible is not the same as proven. And here we talk again about BPC 157, which is mostly preclinical, TB 500, which we know it stimulates angiogenesis, but it is not regulated so far. GHKCU, the copper peptide, has stronger topical evidence than systemic evidence. So before considering anything in this category, the physician must ask, is the diagnosis clear? Is imaging needed, for example, to rule out a differential? In an injury, for example, yes, tendon, ligament injury, just do imaging first, have a medical report first from a specialist before giving the patient the BPC 157 or the cocktail of BPC and TB. You need to follow this framework, yeah, before you recommend these peptides, and to know when to stack and where not to stack the regenerative peptides. I am going to recommend the BPC alone or in a combination with TB and GHKCU and so on, because stacking can multiply uncertainty sometimes rather than multiply the benefit. So you need to be clear on the patient first, and then you can, after, of course, consent of the patient and communicating the clear evidence of the peptides you're recommending, you can prescribe in the peptides. Okay. So the regenerative boundary, while it is very attractive, it is very simple. Do not promise what the evidence cannot support. Just limit yourself to what you have according to evidences. And if the patient wants to take it, no problem. But you need to know what to tell him about the respective peptide. So do not promise tendon repair or surgical avoidance in an injury or scar reversal or pain cure. The right move is first diagnostic clarity, imaging when needed, injury severity assessment through a proper medical report, evidence category framing of the peptide you are talking about, and red flag screening. This does not mean you should ignore tissue repair biology, because it can be very useful. And I know a lot of people using these peptides with a lot of benefits. But we need to discuss it honestly with the patient, the situation of these peptides, where they are actually. The patient deserves to know what is plausible, what is proven, and what remains experimental or uncertain. Another field is mitochondrial support and longevity. So this is a very attractive field as well, also very speculative. Because it speaks to a lot of symptoms our patients come with: fatigue, energy loss, aging, performance. But like I said, it's also quite speculative at present. We have here a couple of peptides like MOTS-C, SS31, epitalon, DSIP, AOD9604. These are examples that require really careful endpoint literacy. And right now, each of them are having clear benefits stated. But I recommend, before using mitochondrial language, to ask about or to check other biomarkers. Like I said, this is the same framework we use for every peptide. Check, for example, in fatigue, energy loss, check anemia, check ferritin, check vitamin B12, check thyroid function, check sleep with, for example, obstructive sleep apnea, check inflammation, check depression, check burnout, before recommending the mitochondrial support peptides to boost energy for a patient. Yeah, a biomarker change is not the same as a clinical outcome. So longevity peptides are often a marketing phrase, not a validated medical indication. Still, if they are recommended correctly, and I say this all the time, they can have a lot of benefits. But make sure the patient is the right one, and make sure you correct other factors as well, which you find out in the lab tests. So what you need is endpoint literacy. Mechanistic aging biology is not the same as animal lifespan. Yeah, animal lifespan is not the same as human biomarker. A human biomarker is not the same as a disease endpoint, and a disease endpoint is not automatically a validated longevity outcome. So there's a long way from a peptide, from an amino acid sequence to a validated outcome. So in terms of longevity peptides, most of them live in the first two boxes, mechanism and animal or early stage trials. We need to avoid to tell the patient, yes, it's going to extend your lifespan, it's going to reverse your telomeres and to elongate your telomeres, it's going to reverse aging and so on. Instead, we can name the measured endpoint. We can tell them, in studies, it has been shown that XYZ, and clearly separate animal data, human biomarkers, and clinically meaningful outcomes. And then the decision of the patient would be much, much better. Other category of peptides are the neurocognitive, mood, and stress peptides. Bring together the nootropic claims and clinical reality. Patients may ask for, what are the main symptoms in which you think to recommend such peptides? Focus, cognition, anxiety, depression, stress, sleep. So here also the evidence, quality, and jurisdiction vary widely. We have claimed peptides like Cmax and CLANG and cerebrolizine. They are not the same from a regulatory or evidence perspective across countries. The physician and you must ask about other factors in this patient. Like I said, the same framework. Is she or he taking psychiatric medication? To know if your peptides could interact with these. Seizure history, insomnia, or sleep disturbances which have not been investigated, like obstructive sleep apnea, for example, which is so often, it's more often than it seems. So we need to check all these markers, all these status in our patient. And when we recommend these peptides, avoid promising cognitive enhancement, anxiety cure, prevention of neurodegeneration or dementia. Be very cautious. Then another category would be the sexual and reproductive peptides for libido, fertility. They are signaling different goals. But patients often conflate them. So we have peptides like PT141 or bremelanotide. We have kisspeptin, HCG, gonadorelin, oxytocin, melanotan-2. They have different benefits, different effects. So they require really also careful framing. Why do I recommend this peptide to a patient? Is it for fertility? Is it for libido? Yeah. So before also we get into the field of these sexual and reproductive peptides, we need to check the patient in terms of sexual hormones, LH, FSH, estradiol, testosterone, all kinds of NSHBG, prolactin, pregnancy status when relevant, of course, and we need to exactly know what the patient wants. Is it fertility? Is it libido? Also, check hormone optimization. Yes, this is one of the first things you need to do in these patients to make sure that they are good in a good hormone balance. And if not, then I would opt for hormone optimization first and then go to peptide. Okay, so avoid prescribing these peptides, especially for libido. Here is a very high pressure in terms of female patients, especially I think you encounter the same frequency of patients who are coming with their main symptoms in perimenopause or even earlier. Their main symptom is libido loss, and they pressure you to give them something for that. So don't offer them at first hand the peptides for libido. Assess them, make a baseline assessment, and make a good sexual assessment before diagnosis, before you intervene with peptides. Now, we have gone through basically the main categories of peptides, and I would like to hear from you which category your patients ask about most. So I put here 4 main categories, which in my practice are the most frequent ones. Type 1 if for metabolic or GLP-1s, 2 for regenerative, 3 for longevity, and 4 for sexual health. So this helps us also to show where the patient demand is the strongest. And it helps also you identify where you may need the most structured training in your own practice, because patient demand often arrives before the evidence is well understood, and you need to address it, of course. Let me see what you answered here. So 3, 4, 1, and 2. So it's mixed 1, 2, metabolic, regenerative. Okay. Okay. So let's move further because we are a little bit late. So I would like to give you a glance of the course of the training I am preparing. This is supposed to be at the end of September, live for 2 days. So in the full course, every peptide gets the same clinical lens. Like I said, the same framework. We will not teach by memorization, just like with the hormone courses. The ones who took my hormone courses know how I am teaching. It's practical, but also a lot of theory to ensure you a very solid clinical background. So we teach by method. For each peptide, we will have the same frame: mechanism of action, evidence group, regulatory category, clinical promise, safety signals, who is the right patient, who is not the right patient, what biomarkers do we need to test, what monitoring is needed, when should therapy be stopped, and what should never be promised. And this repeated structure is what makes the course so practical. And once you learn the method, you can apply it across categories, across peptides, present and future. And of course, we will go through protocols also, because finally, your patient in front of you will not be interested necessarily in the regulatory category or in the evidence group, but will be interested, okay, doctor, you have prescribed me this peptide, how am I going to use it? I'm going home, what do I need? You need this, 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 and we will go briefly also through the dosing protocols as well, of course. But this is not the core of the course, because you need to understand basically how to prescribe the peptides. So at this point, you know the central way of thinking. You have seen the difference between promise and evidence, which is very important, between mechanism of action and final outcome, and how long the way is between this and the clinical outcome and what you can promise to the patient, between approved medicine and gray zone use, and between enthusiasm and real safety. But knowing how to think is only the beginning, and the full system is basically what will you use tomorrow when you are going in your practice in real consultations with real patients who have comorbidities, or they are uncertain and need some advice from you, and what documentation do you need in your practice to be covered when you prescribe peptides to a patient, and what else do you need in order to really recommend, prescribe peptides in a very responsible manner. And this is what the full course is built to provide. Obviously, it's It's not going to be in 1 hour. So basically, this is the invitation at the end of this webinar. And I thank you that you had the patience to wait to stay for over 1 hour. It's an invitation to this training, which I am preparing, a 2-day training, which is called Clinical Peptide Medicine for Physicians 1.0. What we have at present up to date, from mechanisms to monitoring, safety, and longevity applications. And it is a physician level course designed to help you evaluate, select, monitor, and communicate peptide-based interventions responsibly. And the course is not about becoming more aggressive with peptides, but it is about becoming more precise. It gives you the clinical structure to handle patient demand without overclaiming, without improvising, and without relying on internet protocols. Yeah, there are going to be 13 clinical modules. You will receive 9 decision algorithms at the end of the course, and other handouts. It will be 2 days, around 10 hours. So these are the modules. It goes from module 0, which is a pre-course module for pre-assessment, and through module 12. So module 0 will calibrate you before the course begins. And then module 1 to 3 will build the foundation, why peptide medicine needs a framework. We are talking about peptide biology and evidence, regulation and law. Then modules 4 to 11 cover the major clinical categories, as we have gone very briefly today through them: metabolic, growth hormone axis, immune, gut barrier, regenerative, mitochondrial support, longevity, neurocognitive, sexual and reproductive peptides, and aesthetic and skin peptides. And module 12 will be bringing everything together through clinical integration and a case-based decision-making workshop. So the modules are designed to compound, not to sit as disconnecting lectures. Nevertheless, I have named this training 1.0 because I am sure in the future we will add on to this course, making it 2.0, 3.0, and so on as the field evolves. The course is structured over 2 days. Day one focuses on foundations, like I said, metabolic peptide medicine, and we will also cover the growth hormone axis peptides. And this is where we'll build the language, the evidence hierarchy, the regulatory understanding, and endocrine safety framework. And you will get tables, and this is going to be very synthetic and very clear, so that you really can use this at a glance when you need to remind yourself some aspects. Day 2 moves into the clinical categories that physicians are most likely to face in practice. Like we said, the immune and inflammatory peptides, the gut barrier, BPC 157, regenerative peptides, mitochondrial and longevity peptides, neurocognitive and mood peptides, sexual and reproductive peptides, and finally, case integration. Okay, so the order is really intentional. First, we do the framework on day 1, and then we do the complexity and apply this to all category of peptides. A major part of the course is the algorithmic structure. These are decision tools. So dosing protocols matter a lot, of course. You need to tell the patient very precise and very correct what to administer, but you need to have a background. The algorithms will cover whether a patient is a candidate, how to distinguish approved off-label and research use contexts, how to preserve muscle during GLP-1 therapy, how to approach growth hormone axis safely, when to stack peptides and when not to stack peptides, how to monitor therapy, how to stop therapy responsibly. These are the parts you cannot safely improvise from a single webinar or from a social media post. This is the difference, basically. Yes, because between casual use and clinical practice. The course will also include quick reference tools designed to be useful in real clinical work. So these you can use in your practice, have them handy, and until you learn them by heart, you can use them. They include peptide evidence hierarchy card, safety screening card, biomarker monitoring card, peptide category map, red flags, contraindications, regulatory status card, patient explanation phrases, case-based reasoning templates. These are educational summaries, not prescription sheets. Their purpose is to help you think consistently, document responsibly, and communicate clearly with the patient. And this is really a complete physician level learning system. It includes the full 2-day trainings, the workbook, slide. You will have access to the slides 3 months after the course. Peptide by peptide evidence framework, clinical decision algorithms, case-based application, safety and monitoring tools, a complete reference list up to date so far, which is, like I said, changing quite quickly. A certificate of completion you will get. And I want to emphasize again that this is not built as a protocol folder. It is built as a clinical education system. So don't expect from day one to beginning of day one to end of day 2 to see only doses and how to administer. We will state these as well, but the main aspect will be learning about peptides. Understand how to evaluate the patient, how to manage peptide questions, and monitor the patient safely. After the course, the goal is to gain clinical clarity. You should be able to classify peptides, to know if you hear about a peptide, oh, this is there, this is there, I need to communicate to the patient this, that, I need to check these biomarkers first, and so on. You should recognize off-label, approved, investigational, gray zone peptides. You should be able to screen candidates, identify red flags in a patient, select baseline biomarkers before recommending a peptide, design the monitoring plan, communicate limitations without destroying the patient trust, and avoid irresponsible claims or unsafe stacking. So in other words, you should be able to lead the peptide conversation and treatment plan in your practice with structure and confidence, and become the authority in this field in your community. The course is built for physician reasoning, and I think you need to check to see if this course might fit you. So it is for you if you work, it doesn't matter your specialty, but if you work and have longevity patients, HRT patients, menopause, andropause, you work in metabolic medicine, you work in body composition evaluations, for example. You have a lot of patients with fatigue, recovery issues, immune health issues, or sexual health problems. Then this course might be for you, and you want to learn how to approach peptides in their treatment protocols. Also, if you need safety, monitoring, and documentation structure while already prescribing peptides. Yeah. So this is not a biohacking course. So not peptide stacking course, protocol copying, or something like that. So one peptide for every symptom, or anti-aging or regenerative longevity overclaims. It's a very objective course, and it really is intentionally clinical. It's not promotional at all. So it's very very objective in terms of what we have as evidence data at present. Let me ask you one final poll before we move further and close the webinar. What do you think about the standard?
We still have some questions in the Q&A waiting for you, so we're not going to close exactly now, but we'll have the questions as well.
I'm going to close my presentation, then we can take like 15 minutes, we can take some questions, yes. Of course. So just answer briefly if this is the standard you want to practice peptide medicine at, if this is something appealing for you. Type 1 if yes, type 2 if you feel you are getting there, you are not really convinced. Because this question matters because peptide medicine will not disappear. It is just emerging. And the choice is not whether patients will ask, they are already asking. The choice is whether we meet those questions with a mature medical standard or leave the field to less structured voices or to other experts. Okay, so now I will let my colleagues already open the enrollment. Also, for the first cohort of clinical peptide medicine course, besides the two-day physician level training course, 13 modules, like I said, there will be also a live 30-minute group Q&A bonus. And the regular price of the course is 700 euros. And the first cohort price, like for 48 hours after this webinar, will be a special price of 1,200 euros for 48 hours valid. And this is the moment to reserve your seat if you think this is the direction you would like to take in terms of peptides. You will also receive the clinical peptide safety toolkit if you enroll today. And this includes, like I said, the safety and patient selection checklist, which helps you screen before considering peptide therapy. It includes the approved off-label and research use guide. So your clinical communication is safer and more precise. And it includes the monitoring biomarkers reference organized by peptide category, which we will also detail in the course. And for the early bird first cohort, like I said, there will be also a live 30-minute group Q&A after the course. Okay, and yeah, there are basically 3 reasons to enroll now. First, this is the founding first cohort after the first group, which is subscribing 48 hours after the webinar. We will keep it small enough for this live Q&A session for real engagement and relevant questions and personalized answers. A second reason to enroll would be the early price of 1,200 euros. Then after 48 hours, the price returns to the full list price. And I think the third reason, and the most important, would be that the field itself has a window. So because regulations are shifting, the field is evolving, the patient demand is increasing, and the physicians who build expertise now, first ones, are more likely to become the names, the authorities, others will recognize later. So I think you should take advantage. And honestly, I have participated myself. I'm practicing peptide therapy for about 2 years now with my patients, and I'm ongoing joining webinars and also some courses for peptide therapies, for peptide trainings. And I must admit, I haven't seen a course built like this from A to Z in all I have joined. I have just seen peptide listings, not even based on categories of evidence. I have seen dosing protocols. So I have already joined 2 courses, each 2 days. And none of the courses did present this peptide field like this. So I said, maybe it's time to do something broader and more comprehensive and more mature from the clinical point of view. So the invitation is simple: reserve your seat. The team will be contacting you after the webinar if you need support. So for 48 hours, enrollment will be 1,200 euros instead of 1,700 euros after. And I still think that the future of peptide medicine will belong to the physicians who think clearly, not about peptide stacking and dosing, but about evidence, safety, boundaries, and not being the most aggressive protocol users. So if this is the standard you want to practice, I would be honored to have you in the course. So before choosing a peptide, ask these questions. I recap this because it is so important. Is there an indication? What is the evidence level? What is the regulatory category? What are the risks? What do I monitor? When do I stop? What should I not promise? These questions define responsible practice, in my opinion, and they also define the difference between a physician and a protocol seller. And believe me, none of the courses I have attended until now did learn me this. And I have done such a rigorous research on studies to put them together in this training I am preparing. There's a lot. And amazingly, I have found studies also dating from the 1900s, from the year 1900 something. So peptides are studied for such a long time. It's amazing. And I have really searched very rigorously in order to being able to get to this framework for each peptide category. So the clinical judgment is very important. The future of peptide medicine, like I said, will belong to the physicians who think clearly about evidence, safety, monitoring, and boundaries, not about how many mils do I reconstitute a bottle of peptide. Not because they're most enthusiastic, but not because they prescribe the most, these physicians, but because they know how to translate the scientific promise into responsible clinical action. So this is as with hormones, it's basically the same story. You need to have a solid background in order to be very confident and to have the best results. Yeah. So this is the standard I believe this field needs. Yeah. And this is the standard the course I am preparing is designed to teach you. Of course, the full course will include a complete reference structure. So I will give you all references which I am using to fulfill the course. The regulatory and product sources, including FDA, EMA, national labels, compounding and safety risk sources, WADA anti-doping lists. We include clinical human data, such as GLP-1, GIP agonist trials, GH-axis pharmacokinetic and pharmacodynamic studies. All of these I put together, and this is how the course is being organized. And selected trials, for example, for the sexual peptides. Also, the references including safety and monitoring. So basically, I would very much like this training to separate clearly the medical education from unsupported claim making, so that you can be really very confident in what you are doing. And the course materials where you will have access to after the course, like I think for 3 months, they are educational tools. They will not be prescription sheets, but nevertheless, upon taking the course, you will be entering a community in which question and answers will be available. You will get algorithms as decision frameworks, also dosing protocols, quick reference cards, handouts, protocol templates, and everything I have mentioned in the framework in this webinar. Every peptide module includes also what not to promise. Yes, it's very important. So the goal is not to encourage careless use. The goal is to give you a structured way to evaluate, communicate, and document peptide-related decisions. So thank you for your time, your attention. It was a bit longer than expected. Thank you for your interest in bringing a more mature standard for peptide medicine. And I hope this webinar has helped you see why this field is both promising but also complex, and why physicians need to lead with evidence, safety, and monitoring and boundaries. And if this approach resonates with you, I invite you to join um, my first peptide course, which is the Clinical Peptide Medicine for Physicians 1.0. I look forward to seeing you in the course and continuing this work together. Thank you.
Thank you very much. Thank you. We have some Q&A now. If you could open the Q&A.
Yeah, I will stop sharing
Yes.
first. Okay. So, let's see, okay. Q&A.
So the course is online for those who are asking. It will be in September, but you can participate both online, like live, or you can have access for 3 months after that. So we'll have for the doctors that participate in the course, we'll have the recording after that, so you can see it again. Or if you're not able to come live, when we have the live course, you can watch it until December. Okay, so you'll have October, November, and December to watch the course after that. So you don't have to come to Bucharest if you're not from Romania. Everything will be online. Okay, so you can watch it even if you are not available during those days. You can see it after that. But if you register now, you'll have the discount. You can register, of course, anytime until September, but you'll have the full price. So this is the difference. You can register after these two, but you will have less advantages. And as well, the Q&A session that you'll have with Dr. Raluca Hera to discuss about your questions, your cases. It's only for the first doctors who register, okay? So yes, it will be live. Um, a question that I think it's important to start with: what kind of doctors can prescribe peptides? So as I know, it depends on the regulation of every country, but usually all doctors can prescribe peptides, right? What do you think, Raluca? Because we have here different kind of doctors, and they are interested to see if they should register for the course if they will be able to recommend peptides.
Yes, I said that at the beginning of the webinar as well. So you can be any specialty. And it's important to have a training, to have a certificate of having fulfilled, completed training in peptides in order to show it to your patients. So I think every doctor can prescribe. Moreover, in the United States, there are also nurse practitioners, chiropractors, and so on, who are not doctors, who are allowed to prescribe. But I think in Europe, this is not the case. So you need to be a doctor to prescribe. But I think you need a training in this field to be certificated, to have a certification of completion of a course. So any specialty could prescribe. This is amazing in this peptide field. So you can use it in any specialty.
Mm-hmm. Okay, yeah. So this was an important question. This I responded as well in the chat, but wanted to make sure. So you can register for the course because this field is now open to all practitioners. But it's important to not to cause harm and to know what you are doing because it's something new. Okay, we don't learn about this in school. So another doctor is a doctor of dental medicine, if it's okay.
Yes, I'm reading now exactly this question. It's amazing also in dental medicine. So you are already using some regenerative therapies like PRP, for example, in dentistry medicine. So peptides are just an enhancement of prolongation of these regenerative therapies you are already using. So yes, you can use them, of course. because because oral health is so important. It's so important for neurocognitive health, first of all, for gut health and so on. So you need to make sure the patient is healthy altogether.
Okay.
So now
Okay, so
let's take some
the
questions from
Q&A.
Q&A. I will go very briefly through them. They are not from a clinical perspective. What are the most evidence-based applications of peptide medicine today, and in which patient groups do you see the greatest benefit? So evidence-based applications you will see in the course. It's a very long story, and I personally do not know them by heart to tell you evidence-based for each peptide. But in which patient groups I see the greatest benefit, depending on the peptide I am administering. If the peptide is administered correctly with a good indication, they have all that have benefits. And how you distinguish between peptide therapies supported by strong clinical evidence and those that are mainly driven by commercial interest rather than robust data. This is exactly the main objective of the course, to familiarize you with exactly these categories of peptides, to know exactly when you recommend a peptide where it stays. So
But just
I'm
like to have an overview, like you can help your patients if you are gynecologist, for example, even with some infertility problems, you can help them with muscle gain. You can help them to be more, to sleep better, to feel better, to have more energy, to be more, how you say, well aware about what you're doing, to be more focused, to function better with their body or with their mind or with their energy. So you can have a lot of indications. I think the doctor wanted to see if they would have patients for this kind of treatment. So yes, you will have patients. You'll make them feel better. You can complete the treatments that you are already giving them with all kinds of peptides. Yes. Okay.
So you are talking about peptides, but where to get them legally? Only semaglutide or tirzepatide are available. I thought you could help us with what is really available and what does research say to peptides, like so on. I'm not really getting the question. Where do you
Yeah.
get the
So
peptides? So you
yes.
need to find providers in your area or abroad who are third-party tested. So it is not easy. It is not easy to find, but anyways, you need to find serious providers. Maybe go visit their factory and see how their delivery logistic is. See what certificates they can show you, and of course, you need to see what peptides you are ordering, what peptides you are buying from them. Yes, because they can have peptides also that are not approved. Yeah, but anyways, you need to have a serious provider who can give you a certificate of third-party testing with the of the peptides.
Yes, and until the course, because doctors ask us if in the course we'll have a list of such of places, we will have it prepared to give you, depending on your region, um, some providers that offer good peptides where we are buying them as well, and so on. So we'll have it prepared until September, and we will give it to you. Yes.
Okay, so I'm 73 years old, male, have type 2 diabetes on metformin and insulin. Can peptide therapy help me reverse diabetes? There is no such peptide to reverse diabetes. You can optimize your insulin resistance, your insulin sensitivity through peptides, depending on your metabolic status at present. But there is no such peptide to reverse the diabetes,
Like to cure it, but it will
like to cure it.
improve
Yes.
it, but not cure it, like to.
And my wife is 70 years old. She has hypothyroid, hypertension on medication. Will she benefit from peptide therapy? Depending what needs to be improved. So peptide therapy is not replacing the medication for a comorbidity. This needs to be stated clear. Yeah. So, and first, this is the first thing. And the second thing is, if you choose to adopt a peptide treatment for a certain symptom category, like, I don't know, low energy, weight loss, muscle sarcopenia, and so on, you need to make sure that all these comorbidities are compensated, are well treated, and in a stable status. Yes. So nothing will reverse, will cure. Peptides do not cure comorbidities. You need to go along in parallel, like with hormones, with the background treatment of the comorbidities, but they can help to a better metabolic flexibility, or they can help maybe reduce the dose of your baseline treatment. Anyways, they do not replace the comorbidities treatment. It should not be understood like this. Why hormones before peptide? Hormone just correct the balance. Peptide could correct the mechanism for that balance. I understood correctly. So hormones before peptides, because hormones do optimize you on more general level, because basically we do have hormone receptors in every cell of our body, right? And depending, of course, on the life stage of the patient, hormones might be needed before peptides. Peptides are having more specific targeted mechanisms. So a peptide will not act on every cell of our body. It will act on certain receptors depending on the peptide signaling. Yeah. So I would optimize the patient first on a global base with hormones, yes, and then targeted peptides for a certain group of symptoms or for certain issues to correct. And they cannot replace each other. So they can work parallel. Hormones and peptides can work in parallel. But let's say, for example, let's take a very easy example, libido. Yeah, libido you will try to correct with hormones first. Yes, maybe with estrogens, or maybe it's a bit of testosterone, depending on the patient. And these will have also other benefits. While if you choose a peptide for libido, then this will maybe act just on the libido itself. While with hormone therapy, you will have other benefits as well. I think this is the main reason why I prioritize hormones on peptides. Can you give us a list with evidence what is FDA approved and legal to recommend as doctor? This is going to be a part of the course. What's the peptide effects and on holistic microbiome signature? Peptide microbiome axis. Let's start today before tomorrow working. Oh, this is something like a promotion, I think. Will peptides replace Botox and fillers in future, or still unapproachable? So it is known that patients who are taking hormones and peptides need less aesthetic procedures. If they are going to replace them, I don't know to answer this question. But anyway, what I see at present is that patients on hormones or on peptides need less frequent aesthetic procedures. Given the boxed warning about liraglutide and the uncertainty regarding thyroid C-cell tumor risk in humans, how should clinicians approach patient selection, counseling, and monitoring in clinical practice? This is something very theoretical, because in studies, they have not been, and during the treatment cohorts, the treatment populations, there have not been observed any case of thyroid dysfunction, let alone thyroid cancer with this treatment. So, of course, thyroid screening is on the list, like a pre-assessment evaluation before prescribing these peptides, but studies have not demonstrated in populations who took this treatment any case so far of thyroid problems with this product. But it is in the algorithm, in the pre-assessment algorithm, you need to check, theoretically, you need to check the thyroid before. Are the neuropeptides Cmax and C-Lung and cerebrolysine available in Europe, or they're only in a research phase? Cerebrolysine is available in pharmacies. So this is an FDA-approved product, which we are using in our clinics, also in IVs. As neuroprotection. So this is a product you can get right away in the pharmacies. Cmax and C-Lung are not yet FDA approved. You can buy them at peptide providers. Okay, thank you. Thank you. Okay. Are they approved in Europe by legal pharmaceutical bodies? I don't know what exactly you mean here. So they are, like I said, they are peptides who are already approved, FDA approved, also in Europe, like the GLP-1s, the growth hormone, yes, the growth hormone itself, and other peptides, and others that are not approved. You cannot find them in pharmacies. But the approved ones you can find also in pharmacies in Europe. So, so far I have finished the question and answers. Let me see if there are also in the chat. The course going to take place in Bucharest. It is going to take place online. It has also already been answered. The course will be live online, and then you will have access for 3 months after. Okay. I think this was
I replied to all the questions.
yes.
Some doctors wanted to become your patient in HRT. I give them your work number to contact you for that. So yes.
Yeah, it's interesting because maybe some of you are for the first time interacting with us today. Some of you might know about our other courses, but I will take the opportunity to mention also the other courses we are offering, which are very valuable in the context of if you want to do longevity management, longevity protocols. We do have a hormone course. HRT course for women, beginners and advanced course. So 2 separate courses. We do have a Dutch test course, which is helping you to interpret the Dutch test in monitoring HRT. And we do also have some short modules courses, but unfortunately, these are all only in Romanian. About premature ovarian insufficiency and premature menopause, about premenstrual syndrome, PMS and PMDD, and another one about HRT and cancer. Maybe we will think to translate these modules as well, because they are very sought of, very inquired. So if you think you would like to manage your patient on a holistic basis, also with hormones, but also with peptides, maybe you can, it's worth to take a look at our other courses as well.
Yes, sure. So our team will be there. By the way, if you want a certificate after this webinar, I posted in the group. You can contact Miriam, and she will give you a link to complete some form, and you will get the certificate after this webinar. Of course, you can register whenever you want for the course. In the next 48 hours, you will have a discount as well. So thank you very much, everyone, for being here with us in this lovely Sunday morning. And
Yes. And I just want to mention the course. I'm just looking up now. We have set up the course on the dates of September 25th and 26th. So September 25 and September 26th. Each day will be approximately 5 hours.
yes, exactly.
And I hope to see you there.
Yes, so I put here the link as well, but you are in the group, I think, so you can find the registration link, because in the registration link you'll have all the details, what the course consists in, what are the dates of the course, and all the details that you need. So it's easier just to click the link and see all the details there. And we're looking forward for that. And as well, so we'll have prepared a list of where you can buy peptides, because this is another important information, and we'll have a discussion about that as well, pros and cons and a lot of things. Okay, so thank you very much everyone for being here, and see you next time.
Thank you. Bye.
Thank you.